Hello everyone. We have a 50-year-old lady and she come to emergency department with 2 days of abdominal pain, nausea and vomiting. The pain was initially intermittent coming in wave, but over the last 6 hours it has become severe and continuous. She has vomited 3 times over the last several hours but has not passed gas or had a bowel movement for the last 3 days. Okay. Well, there was a large benign ovarian cyst which was removed 10 years ago. At the moment, she has fever, BP is very low, tachycardia is there, and mucous membrane are dry that indicate dehydration is there. Abdomen is distended, tympanic and tender to palpation in all the four quadrants. Mild guarding and bowel sound are decreased. And as far as leukocytosis is there, blood glucose is normal, their blood urea nitrogen slightly increase, but definitely metabolic acidosis is there, amylase is in the normal range. X-ray abdomen shows distended loop of small bowel with air fluid levels. The next best management in this patient is, well, in this case, we should do urgent surgical exploration as per NICE guidelines. The patient presentation is consistent with complicated small bowel obstruction. Now, this is a beautiful X-ray. This is self-explanatory. Multiple fluid levels. Look into it has been marked by arrow also. This indicates small bowel obstruction. In fact, this is a golden line to remember. Anywhere you are getting multiple air fluid level in an X-ray, abdomen in standing position, that indicate small bowel obstruction. Such a simple, okay? Now, patient with small bowel, typically they come with colicky, abdominal pain, the way this patient has, vomiting, this patient has a lot of vomiting, inability to pass flutter or stool, he has not passed a stool for last 3 days. Abdominal distension and diffuse tenderness. He has a patient has the pain all the four quadrants. That means diffuse tenderness is there. History of prior abdominal surgery is important risk factor. Like in this patient was operated for ovarian cyst. So that is the point of the past history is there. And increased pain and hyperactive bowel are sometimes noted during peristaltic. Initially, there are always hyperactive bowel sound when the bowel are obstruction, but later on, the pain, this sound become diminish. Okay, so you can say like this initial stage, later on, this is the bowel activity, simplest, that self-explanatory, predominant feature later on, it become pain disappears. Depending on the level of obstruction, abdominal radiograph can reveal dilated loop of bowel with multiple air fluid level, which I have shown you in the X-ray. Mild leukocytosis and amylase elevation can also be there. But like in our case, the amylase level is slightly increased and TLC count is also more than normal range. Most patients can be managed initially with conservative measures. Okay. So how we do manage, we can go for bowel rest, nasogastric tube suction, correction of metabolic derangement. But our patient has several findings that indicate complicated SBO with increasing risk of impending ischemia, strangulation and necrosis. Because if a fracture is not released, it can lead to ischemia, strangulation and necrosis, and that needs urgent exploration. Surgery is needed. Well, what are the findings which are favoring pain in changing character of pain? Initially, it was coming in waves, but now it's continuous. Fever and hemodynamic instability, hypotension, BP is so low, tachycardia, 122 is the pulse. They're all signs of severe thing, and moreover, in addition to that, guarding and leukocytosis, TLC count is raised. Metabolic acidosis, bicarb is 15. Okay, that means even acid base derangement has occurred. So now you cannot afford to delay surgery. It has to be done immediately because there are so many warning symptoms that patient is going into complicated state. Now let's look into other option. Broad spectrum antibiotic and serial abdominal X-ray. Antibiotics should not be used in patients with uncomplicated SBO. There is no role. Patients such as this one, who has complicated SBO with suspected strangulation, have increased risk of bacterial translocation and sepsis. So we can use, it can reduce infection, but this is not the first line treatment. You have to operate to save the intestine. This is not going to save the intestine. So antibiotic and observation, serial X-ray alone would not be appropriate for this patient given the clinical deterioration, worsening pain, fever, acidosis. What about contrast enema is not useful at all in any way suspected case of SBO. CT angiography for mesenteric ischemia, this we do when we are suspecting because some mesenteric obstruction, because mesenteric ischemia may also present with similar sign and symptom, pain, vomiting, dissension, decreased bowel sound, and peritonitis. Okay, but air fluid level are characteristic of SBO. In fact, as I told you, golden line, if you are getting air fluid level, that is 99.9% you are dealing with small bowel obstruction. CT angiography is preferred when there is acute mesenteric ischemia, which is not in this case. Well, rectal tube placement, this is colonic pseudo-obstruction. Obstruction without a mechanical cause may also present with pain, abdomen, and vomiting. Imaging would increase show a dilated colon, which is not there in our case. So a quick recap of the last minute revision point about small bowel obstruction. The clinical feature, colic, abdominal pain, vomiting, inability to pass flatus and stool. Very, very important clue that happened in our case also. If it is complete obstruction, okay, and there is no but there is no constipation. No constipation if it's partial. And moreover, you are getting hyperactive and initial hyperactive bowel movement, later on absent bowel movement, distended and tympanic abdomen, dilated loop of bowel with air fluid. This is virtually diagnostic. Again, gold air fluid level means you are dealing with small bowel obstruction. Partial air in colon, but complete transition point, abrupt cut off. There is no air in the colon. Complication, ischemia, necrosis, strangulation, bowel perforation, they are all surgical emergencies, should be taken on the priority basis. Management, bowel rest, nasogastric suction, intravenous fluid initially. Later on, surgical exploration, the sign of complications are there. Golden line to remember, immediate surgical intervention indicated for patient with interstitial obstruction who develop clinical or hemodynamic instability, BP low, metabolic acidosis, failure to improve after conservative treatment, delays symptom or sign or develop symptom or sign of ischemia or necrosis. Thank you very much.